Over to you, doctor.
Yeah, just 1 minute. There's still issue in recording. Can you see my slides, sir?
Yeah, slides are there. Yeah.
Yeah. Well, good afternoon, doctors. Welcome to this webinar on role of Oseltamivir in flu management, brought to you by Heathrow Healthcare. Heathrow Healthcare, as you all know, our journey began in 1993 we have got 30 years of excellence, 36 state-of-art manufacturing facilities, and 300 plus production portfolio. We have presence in 126 plus countries and 21,000 employees globally. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Heathrow Healthcare, a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, introduced Oseltamivir, Favipiravir, and Remdesivir for the patients, for which they received an award of Pharma Excellence in August 2020 for COVID drugs. In today's webinar, we cordially invite you for this webinar. We have got Dr. Anil MU and Dr. Somashekar with us. Professor Dr. Somashekar is Professor Ramaya Medical College, pediatric pulmonologist and adolescent care specialist, President IIP State Respiratory Chapter 2015-16, Treasurer IIP Allergy Chapter 2015, IIP State Allergy Chapter, Joint Secretary IIP Bangalore 16, Secretary AHA 2016-2017, EB Central IIP Respiratory Chapter, EB Central IIP 2015-2017, Secretary IIP State Allergy Chapter 2021, Chief Editor Pulmoscan, Executive Editor Journal of Pediatric Pulmonology, EB National Respiratory Center, Secretary Environment Chapter of Child Health Group, IIP 2023-24, President IIP Bengaluru 2024. Dr. Anil MU sir is MBBS MD Pediatrics and Fellowship in Pediatric Critical Care, Diploma in Allergic and Asthma, Lead Consultant Pediatrics and Pediatric Critical Care, Sparsh Hospital, Bengaluru. With this brief introduction, I hand over session to you, Dr. Somashekar. Over to you, sir.
Good evening, all, and thanks for this very important topic and opportunity created by the organizers. And we are talking about something on today on flu and the need of oseltamivir and what is the current trend of the case scenarios are going on, any complication we are anticipating, everything. To discuss with me, we have Dr. Anil, none other than very good, my close friend, as well as very good intensivist and is an allergist also. Presently, he is a lead consultant at Sparsh Hospital. What I know about him is whenever we give a topic or present him, he go to the depth and work. And we got even the feedback from the patient care is most popular amongst other patient and his colleagues also. Welcome, Dr. Anilia.
Thank you, sir. Thank you for the kind introduction.
Nice of you.
Hopefully, we'll have a nice discussion over
Definitely.
the next 1 hour to
It's
clear the topic which is going around about the flu and influenza-like illnesses. I think we'll have clarity towards the end of this.
Yes, dear. Thank you. Dr. Anil, this right now the season of flu is going on. And we are getting like here and there sporadically or maybe more than that. The case of flu is also there. How to differentiate between the flu and the non-flu cases?
Yes, sir. Definitely, there is an epidemic for sure. I think as clinicians, when our OPDs get busy, we know that there is something that's happening. And this season, it's been the season of the flu. Usually, we do see these epidemics going on in seasons. And typically in India, this happens after monsoons. And this year it has started. And we are in the midst of this epidemic for this year. And probably compared to last year, probably the number of cases is much more in this year. And the OPDs have been flooded and we pediatricians have suddenly gotten busy over the last month or so. So that kind of tells us we're in the midst of a flu season. This year, probably we didn't have much of dengue cases, but the flu season is keeping us busy right now. And in such a season, as you rightly asked, sir, is it influenza? Is it something else? We need to be very, very careful in our OPD practice when we are doing it. So the differential diagnosis for what we call as a ILI or influenza-like illness, because when the patient comes to us, we don't know what is happening. So definitely we have a patient who comes to us with a acute febrile respiratory illness of varying proportions. Some may be very mild, some may be moderate, some may be very severe. So as a syndromic diagnosis, we make a diagnosis of influenza-like illness in such conditions.
Yes.
So even before we jump onto the bandwagon and label that as flu or not flu, we should be aware as to what could be the differential diagnosis over here. So it could be a flu or non-flu respiratory viruses which are going around. When we talk about the non-flu respiratory viruses, we have the whole lot of other viruses. RSV, yes, RSV epidemic is still on, going on.
Yeah.
We have the rhinovirus, which has been there for ages and which has been troubling our babies, especially small babies. We have adenovirus, which has been there, and we had the scare of human metapneumovirus very recently, where all the
Yeah.
media had picked up on the human metapneumovirus,
Yes.
influenza viruses, para-influenza virus, and of course, we can't forget the COVID pandemic, which is right behind us.
Yes.
So we need to have this differential diagnosis of non-influenza kind of illness. There are a little bit of clues. I just want to spend a minute or
Yeah.
two on these things. So the most commonest what we see is common cold kind of a presentation. When we have a small baby presenting with, it's a systemic illness, but we get a small baby having more of a rhinitis, more of a nose block, more of conjunctivitis, nose block, mild fever may be there or may not be there. So these cases, most probably it's because of a rhinoviral infection. Rhinovirus, even though it's a systemic infection, it's more localized and it's a milder variant and it gets better. Whereas the flu or influenza group of viruses, it is much, I would say, the fever is much higher, sudden onset of very high grade fever, headache, body pain, and sore throat. It goes on to develop a little bit of sore throat, headache, body pain, myalgia, and severe myalgia. This is very typical of a flu-like illness where we suspect influenza group of viruses. Whereas adenovirus is one virus which comes with a similar, it's a slow progress. It doesn't come with a very high grade fever from day one, but gradually it kind of steps up adenovirus. And we see children coming to us by day 4, day 5 with high grade fevers. Eyes are becoming red. They may have a ropey kind of a discharge. And that is a classic adenovirus for us. And when we look at children, small children, especially when they're little croupy, they come with a croupy kind of a cough. That is again one symptom for us to diagnose probably a para-influenza virus for us. And adolescents and little older children coming where we have less signs and too much of symptoms, we should not be forgetting mycoplasma, which can masquerade as a flu-like illness. And these are all about the respiratory illnesses. Whereas when we think about the non-respiratory illness, dengue is something we should not forget.
Yeah.
Dengue also on day 1 and day 2 come with very high grade fever, headache, body pain, and that typical conjunctival
Yes.
injection will be there. They'll also have a severe headache, body pains, pain in the back. So on day 1 and day 2, it becomes little difficult to distinguish clinically between the two. But if you take a detailed history, I think these are the pointers we get. And also, we should not forget the environmental triggers, like someone who is severely allergic and suddenly gets exposed. They may come with a lot of coryza, they may have a flare up of allergic rhinitis, they may start wheezing, and which may be viral triggered also. So, the allergic patients also we should not be forgetting. And of course, the bacterial illnesses we should not be forgetting at all. The Haemophilus influenza, a streptococcal sore throat, or a pneumonia, low respiratory, we should always keep in mind that these could be a possibility also when someone presents to us with ILI, that's an influenza like
Like, Would
illnesses.
you explain everything gamut of infection, right from non-flu infections and bacterial infection, adolescent, not to forget about mycoplasma, all good. But let me know, see, we are talking about flu and we are little worried also. What are the red flag signs? Like, even other virus also can progress and deteriorate. But it is more, little more conscious. We should be like, we should be alert related to that. Can you tell me some, how to identify, how to think it's a influenza like illness, as well as some red flag signs if you're there, please let me know.
So, yeah, of course, as soon as we make a syndromic diagnosis of ILI, influenza-like illness, we need to systematically we need to classify them into whether they're into class A, class B, or class C. Class A are the minor kind of illnesses which we treat on OPD basis. little bit moderate symptoms where they have a very high grade fever, severe sore throat, will be classified as category B. And category C is the sick ones where we need to immediately admit them and attend to them. So probably when we talk about red flag signs, we are talking about the class C kind of patients who needs to be flagged immediately and the right measures can be done. First and foremost, very high grade fever, drowsiness, more importantly, how the child is in the interfebrile period. Is the child becoming active or becoming very dull, lethargic, and is there any refusal to feed? Probably these are the main red flags that we see. Any kind of fast breathing, any kind of lethargy, child progressing on to a severe respiratory distress, or becoming drowsy, lethargic, which is pointing us to some sort of CNS complications, and inability to feed himself or herself. These are the red flags that we should be careful about when we are dealing with these kind of viral illnesses, especially the influenza-like illnesses.
Okay, like, can you tell me some specific condition where they deteriorate fast? Like, some are high risk. Like, if you take, I'm sure. Tell me, how is your like, ICU about these flu cases? Are you getting more patients there?
We are getting lots of cases, sir. They
Oh,
usually,
nice.
these are the respiratory distresses which are ending up in the
Yeah.
ICU, and we have had some children with CNS complications ending up in the ICU. And
Oh,
very rarely they go on to a multi-organ involvement where they require multimodal support. They kind of end up in the ICU. But so far, luckily for us, this year it's been only the respiratory involvement and few cases with CNS involvement
yes.
who have been coming to us. So when we are talking about the risk factors, whom do we consider as high risk factors we need to look at? Extremes of age, whenever we are getting very small children and even adults who are more than 65, we consider them at very high risk for complicated flu-like illnesses because their immunity, as we know, at the extremes of age, at the very young age and very old age, the immunity kind of wanes. So these age group is considered at very high risk and the pre-existing other chronic diseases. It could be a pulmonary disease, a cardiac disease, a liver disease, any condition which is compromising on the immunity. We have any autoimmune diseases going on, a chronic renal insufficiency going on, or any kind of immunodeficiencies kind of predisposed for these. These are the group where we would consider as high risk. And of course, we should not be forgetting our urban population where we get lots of obese children,
Obesity. Yeah.
where the BMI is more than the 95th centile for the
Mm,
age. These are again at very high risk
yeah.
for developing complications.
Yeah, rightly said. Right, we should know about the risk complication, risk category. Then only we can have an index of suspicion.
Yes, sir.
But after being said that, like, when it's is there, epidemic is there in the OPD practice, it's a busy practice. You all know. You do patients the nasal swab test or whatever the PCR, whatever it is you do for what category you do when you will suspect in the OPD. IPD we know we do, but OPD setup. When you will suspect, when you will select the patient, how you will select the patient?
On routine, day-to-day routine OPD practice, doing a swab test to confirm influenza may not be really warranted for the milder cases where we have a category A kind of patients who present to us with high-grade fever, headache, body pain, little bit of respiratory symptoms. They may have a dry, non-productive kind of a cough, but they're still active in between the fever episodes. Their oral intake is not compromised and they're doing fine. We should always, as pediatricians, remember that influenza is a self-limiting illness. In otherwise well child who is active, able to feed, and all these minor symptoms are self-resolving and they will resolve within 5 to 7 days, the child will be fine. So in such kind of patients, definitely swabbing them may not be really required. Only for epidemiological reasons to know what virus is going around, probably the swab may be indicated, but otherwise for a routine case management, anybody who is in category A may not warrant a swab test to be done. In our practice, what we do, probably anyone who is sick enough to get admitted, that is moderately sick to severely sick, anyone who is warranting admission for whatever reason, then probably it is worthwhile to swab them. So that's what we also follow.
Good. You have clearly said about when you will do the swab test and everything. But let me know your policy related to Oseltamivir in the OPD practice as well as in the IPD as well as in the high dependency area.
Yeah, again, on the OPD kind of a scenario where we have a well child or a well adult who has very mild symptoms, would could be like a ILI, influenza-like illness, mild symptoms, probably we would wait on oseltamivir on a specific antiviral treatment. It is not recommended that we start them for anyone who is on a very mild kind of illness. Similarly, like I told, for swab testing, where we would do a testing for someone who is moderately to severely sick, anyone who is getting admitted, probably yes, we will go ahead and start them on oseltamivir. There is a proven case in the household and we have high risk people in the household, yes, that it will be worthwhile to start them on treatment dose of oseltamivir. When I say high risk, we could have a grandparent who is aging, who is diabetic. We may have a grandmother who is probably having a renal issue, someone else who is obese. They may have a pregnant person at home. If at all the exposure is there, and we have all these high risk people at home, then probably it will be worthwhile treating the suspect cases as well.
Good. One more thing is nowadays, if the pregnant mother delivered and she's lactating, just let us assume 2 weeks baby is there, mother is positive, and baby has developed little symptoms. Is there any word with oseltamivir? Any prophylactic word is there with when we are using oseltamivir?
Yes, oseltamivir prophylaxis is definitely, we need to look into it. But when it comes to this very young newborn at home, so the literature tells us that the oseltamivir prophylaxis should be avoided for less than 3-month-old babies. When it
Okay.
comes to treatment, yes, 14 days is what the literature says. The CDC says that 14 days is the cutoff where we can use it. But if at all there is a sick baby in the NICU who is really sick, even less than 14 days, oseltamivir can be used in the appropriate doses.
Oh.
So, word of caution in using prophylaxis. Usually, less than 3-month-olds, it is not preferred to have oseltamivir prophylaxis. And again, in treatment, less than 14 days of age, usually we don't prefer to treat babies less than 2 weeks with oseltamivir.
So you said clearly that extreme age, if at all sick neonate, you can use at the age of 2 weeks, but be cautious. Just mild symptom not required.
Yes,
But otherwise, less than 3 months, it is not indicated
not
as a
not indicated. Prophylaxis is
place.
not indicated less than 3 months of age.
Dr. Anil, just let me know about the side effects, complications, adverse effects, anything related to Saltamir. What we can.
Oseltamivir, I think earlier we didn't have much experience with oseltamivir, and as and when the drug became available and we've been using oseltamivir, more and more confidence we have gained with oseltamivir. This drug, usually it's a prodrug, gets converted into the active metabolite later on, and then it acts on the neuraminidase inhibitor so that it reduces the multiplication and release of these new virions into the other system so that the other cells are protected. So that gives us a quicker recovery. And thankfully or fortunately, this drug is quite a safe drug, doesn't have much drug to drug interaction. Even among the adults who are on multiple other medications like your anti-diabetic, antihypertensive, and whatnot, usually this is a quite a safe drug to be used in the situations, doesn't have a drug to drug interaction. And coming to other adverse effect, usually we don't come across any serious adverse effects. So there are some GI side effects like little bit of nausea, little bit of vomiting, which are again self-limiting usually. These are the only ones. Usually any specific hypersensitivity reactions are not usually recorded with this medicine. But a word of caution to be used in especially cases with renal insufficiency. Anybody who is having a renal insufficiency, we should be extremely cautious and use it in a renal dosage. Renal calculated adjusted dosage, this oseltamivir has to be used.
You said clearly it's a relatively safe drug, but when it comes to renal dose should be adjusted if you are suspecting any renal disorder, ongoing renal disorder.
Right, sir.
Right, is it? Good. Dr. Anil, let me know, like, in OPD practice or in the IPD also, how early we can start Oseltamivir? How late also? Sometime now we'll have our dilemma in the unit and we'll wait and other things. Sometimes we have crossed at 3 or 4 days of whatever the golden period also. How late we can start?
Like we discussed, oseltamivir is a neuraminidase inhibitor. So basically, what we are trying to do is lessen the spread of virus within the host so that it is cleared earlier from the host. So by using this, what we are trying to achieve, we are trying to achieve a early clearance from the body. That's what we are trying to achieve. And by using oseltamivir, usually the what is the advantage if someone is not given oseltamivir and the people who are treated with oseltamivir? Number one, it prevents the progression of the disease from milder forms to severe forms. It halts the progression into severe, much more severe forms of the disease. Second, it shortens the duration. See, the natural duration of natural course by which influenza progresses is 1 day prior to the onset, someone is infective, and this period of infectivity goes on for up to 7 days. And by 5 to 7 days, it's a self-resolving kind of a systemic illness which resolves. So by using this oseltamivir, the duration can be reduced. So what is the duration which it can be reduced? So the various studies which have told us anywhere between 1 to 3 days, it can lessen the duration of this kind of illness. So someone who has gone through this influenza-like illness can vouch for the uh, discomfort that the myalgia causes, severe body ache, severe throat pain, and this kind of a hacking, dry, unproductive cough. It's very, very troublesome. And if you are getting a benefit of, say, even to 1 to 1.5 or even 2 days of benefit, that your symptoms are resolving much faster, I think it is worth it. So this oseltamivir definitely gives us an advantage. And at the same time, there are multiple studies which tell us if it is instituted within 48 hours, it gives us the best results. So it halts the progression of the disease and even the recovery is much faster. So ideally, in the first 48 hours, if it is initiated, we will have the best response. But for someone who, as a admitting unit, and we are getting referrals, and we have patients who come to us on day 4, day 5, they've been treated with antibiotics and nebulizations, and they're not getting better. So by day 4, day 5, also they do land with us. In such situations, we don't hold back just because it is day 4 or day 5 of illness. If it is day 4, day 5, and we are seeing that there is a natural course, there is an improvement. So the fever is gone now. Child is entering into that afebrile period, and probably then that situation where the child is becoming more active, we can hold back on it. But if someone is becoming having a progressive disease, is requiring hospitalization by day 4, day 5, we definitely go ahead and start. And much more sicker patients. When we get a child with ARDS, when we get a child who is comatose, who is encephalopathic, who is seizing, especially and febrile and seizing and febrile and comatose, we know that in this season of this epidemic, even empirically, we go ahead and start them on oseltamivir, even though as a syndromic diagnosis, when they're really sick, we go ahead and start them on it. So early treatment is obviously preferred. If it is the syndrome is identified within 48 hours, definitely it is preferred. And for someone who is sick, moderately to severely sick, and they're presenting even before, after day 4, day 5, I think it is worth treating them
Worth
with
trying.
oseltamivir.
Good, you cleared it and you said it is worth how early we can by 48 hours, but you already said about the need of the sick patients like comatose or severe ARDS. We can go ahead with even a fourth, fifth day also we can start. It's a note of benefit, or definitely it may help in outcome of the disease. But
Right. So,
sometime in the ICU, what happens? We have done a patient with a moderate pneumonia or whatever the respiratory, it has come. We have done the swab test. It has come negative. But we have started with oseltamivir. What to do? Can we
so
stop the medicine or to continue?
we need to evaluate the syndrome which is going on.
Yeah.
Someone who has an alternative diagnosis which can explain this. For example, now when we do a swab, especially in the metros, when we do a swab, it is not a single influenza that we are screening. It's a multiplex PCR panel. Many a times the other viruses will pop up. Most probably the RSV season is going on. So the RSV may be positive. We may get the COVID. Fortunately, we are not getting COVID, but During COVID season, we had a lot of cases who had co-infection of COVID and the flu. And many a times there can be a bacteria which can pop up. So we need to evaluate for this to find out, is there any alternative diagnosis to this? We kind of look at the clinical syndrome which is there. If they have a very classical clinical syndrome of flu, like a fever, headache, body pain, non-productive cough, sore throat, which has progressed onto this, then everything clinically it is pointing out towards influenza. And when we do a RT-PCR, sometimes we may get a negative report, but we don't have any other virus, any other bacteria also. We are strongly clinically thinking in terms of flu itself. Then I think, and the child is not getting better. If the child is getting better already and the flu comes negative, I think confidently we can go ahead and stop the oseltamivir if the child is getting better. But if the child is having a progressive kind of an illness, not getting better, progressively worsening, and clinically, our clinical acumen says that this could be flu, I think it is worthwhile to continue with the oseltamivir. At the same time, we keep looking for the other alternative diagnosis also.
Say high index of suspicion, about trying, even though it's negative, give a dot of benefit. And of course, you should keep evaluating, look for the alternative diagnosis, all those things.
Right, sir.
But if the swab test has come positive, you have started with oseltamivir, and persistent symptoms are there, you give in your unit antibiotics?
Uh,
We are talking about antibiotic stewardship related thing.
Yes, doing a swab test and the influence has come positive, and we have started someone on oseltamivir, say for 48 hours. So classically, our clinical acumen says that this is a viral kind of a respiratory illnesses. We have a mucosal involvement, we have this non-productive cough, and there is epidemiological evidence that in the community currently the flu is going around. But still, even after 48 hours, we are seeing that the fever is not abating even after 48 hours of appropriate antiviral therapy. The child is becoming more sicker, and there are other systems which are getting involved. Probably we need to keep our antennas up. We need to keep searching for other sources of infection, like probably tonsillar crypts. We need to keep looking at the whether the child is developing any follicular tonsillitis, how the throat is looking at, and the lungs. Is it any localization is forming? Like we can get the X-ray done to look at, is there any lobar kind of an involvement or any segmental involvement which is there, which is again pointing us towards a bacterial kind of etiology. Also, we look at other sources, multi-system involvement. We need to look at the urine and other things. And is there any kind of a focus which is forming elsewhere? Yes, in that situation, I think we should still not sit with the without starting antibiotic. We take appropriate cultures and start them on antibiotic, but still continue because of our clinically we know that this is looking like flu. We still continue with oseltamivir with the antibiotic in such situation.
So it's a progressive disease, any rise cause or any picture of consultation, give a picture also, or localization is given a lot of importance, I think. So there we
Yes.
can give a trial of antibiotic.
Yeah, and at
One,
the same
yeah,
time, we take help of the our laboratory colleagues.
yeah,
Dengue, which may be missed on day one and day two, we need to
yeah,
revisit and check for the platelet count as to what is happening. Get
yes.
our dengue ELISAs done, chest X-rays done, appropriate cultures done, and then probably move ahead.
Good. One vague question. So child has come, recently vaccinated, developed respiratory symptom. Do you give oseltamivir? Or how will you evaluate? How will you convince the patient, first of all?
So this becomes a very tricky situation because we would have convinced the parent to go with the flu vaccine, telling that the flu monsoon is starting and the flu season is right around the corner, and your child will be protected by using the flu vaccine. But at
Yeah.
the same time, we should not forget to tell them the flu is protective against the severity of illness, and the at best the flu vaccines give up to 70% kind of a protection. So we also can explain them because after COVID, I think most of them know about this change or the strains of the viruses also. There is a influenzas are notorious to have this slow change in their antigenic structure, what we call as the antigenic drift, and also a sudden shift in their antigens also to present as a different variant or a different strain of viruses. So that could be a possibility. We need to be very careful in explaining them that this could be a different strain of viruses. And of course, you are taken the flu vaccine that will prevent against the severity of illness for sure. But to prevent the spread, we still need to go ahead and give the child the oseltamivir.
One thing, yeah, when in the practice, I think we should explain that we should give them the time, tell them the indication of this vaccine and the and percentage of protection should be explained, I think.
Right.
Otherwise, we even in pneumonia, we know, no, they'll come, we are given very expensive vaccine, still they have better, we should explain them.
Yes.
One more thing is if you're given the vaccine next week, they come with a respiratory symptom. Any chance because of the vaccine they'll become positive, nasal swab can become positive? Vague question.
No, sir. No, no. This what we are using is when we are giving a vaccine. If we are not using the live attenuated vaccine currently, it's not available. The nasal
Mm.
vaccines we are not using. We are using the subunit vaccine which we are injecting, and that can't give us a nasal swab positivity at all.
Okay, good. And we spoke about antibiotic stewardship. Good. My question is about why we should be cautious. Of course, we should be cautious with every drug. Oseltamivir, is there any reports related to resistance or how it will be? Like, how we should be cautious to keep it for the future?
No, like any other drug, I think as doctors, first we do not do any harm. Whenever it is not required, there is absolutely no point of using it. And with the rapid usage, lots of people now after this season looking at our prescriptions, lots of other kind of doctors, I want to put it as, they will also start using this oseltamivir molecule right, left, and center. When you should be very careful with the indications. When it is used very inappropriately, yes, there is this question of developing resistance among other viruses. Then we don't have any other choice to go for. So we need to preserve this molecule to treat the severe most forms of these illnesses, flu-like illnesses.
So we should be very clear when you are giving oseltamivir and be judicious. Okay. And one more thing is like no preschool era, and even the children go to school at age of 2 years, 1.5 year, play home, all those things, and a lot of infections are there. We can't convince the parents. And if a child is there with the symptoms of respiratory or flu has become positive, when he can go to school? Because working parents, they will ask you.
So the guidelines tell us 24 hours of fever-free period, and that wellness is what is required before the child can go back to school.
Okay.
But the period of infectivity is 1 day before the onset of fever, and up to 7 days they can spread. So ideally, especially in a preschool kind of a setting, I think we should follow the similar kind of guidelines. At least 1 day of fever-free period and the cough should have subsided, then probably
Yeah.
we can send them. That sensation of sense of wellness should come, and at least 24 hours of fever-free period should happen. Then probably we should encourage them to go back to school only after the symptoms have resolved, especially in a preschool kind of a setting.
Even with that, what is the chances of their spreading, even though symptoms are fine? First week, any likely chance of spreading the infection in the first week of their resuming back to the school?
Up to 7 days, they can shed the
They can go,
virus.
no?
They
Yeah.
can shed.
So we can't just take care of the 24 hours of February period. Of course, cough should be one of the marker to say that if they got severe productive cough, and at least for 7 days we should monitor that, I think.
Right, sir.
That will be good.
Yeah.
So, Anil, I want to know something. You are intensivist. 2, 3 case scenarios from your side. Recently, you are treated.
So the most commonest scenarios that we get in our hospitalization, I'll say from the probably the mildest to the severest forms that we would have seen.
Yeah.
So the commonest referrals or patients who are coming to us right now are the ones with with a acute febrile respiratory illness. They would have seen, and rightfully, as we pediatricians, we kind of assess the situation. Probably they would have seen the doctor on day 1 or day 2 of illness, and probably 48 hours managed with supportive care. And once they land up on day 3, usually most of them antibiotics are started. So by day 4, there is no response with the antibiotic, and the child starts becoming tired towards day 4 or day 5. So that is the most commonest presentation we are getting with respiratory symptoms, and they're coming to the hospital on day 4 or day 5 of these acute febrile respiratory illness with or without distress. Few of them have little bit of respiratory distress, and these are the milder variety for us who to manage in the hospital. So symptomatic supportive care, and anyone who is sick enough to get admitted, we swab them and they're started on Oseltamivir and the other labs to guide us, and the X-rays to guide us if at all we need to start them on with the antibiotics also. That's a decision we take on case to case kind of a basis. Those that's the most, I would say, in a hospital setting, these are the mildest cases that we get. And then in the HDU kind of a setting, these are the same cases who have progressed over the last 4 or 5 days. They land up in respiratory distress, requiring oxygen. Sometimes, especially children with very acute history, within 1 day of febrile respiratory illness, they start wheezing, they go into a bronchospasm and they're requiring multiple nebulizations, oxygen. What like a status asthmaticus kind of a presentation with a respiratory high grade respiratory fever, and especially the ones who have a family history of atopy or had a history of wheeze, they are landing up with acute respiratory distress kind of a situation. So, and then we see the other lot with complications of these respiratory illnesses. Like recently, we have had few cases of CNS involvement. Febrile deliriums are very common with influenza group of viruses because of the high temperatures that we see. Febrile seizures are very common. Febrile deliriums are common in little older kids. They become delirious at the height of fever. They're confused, but they once the fever is controlled, they're doing all right. They don't have any meningeal kind of symptoms. And we do see encephalopathy also. The febrile encephalopathy influenza, it's a very well-known cause for developing a febrile encephalopathy. So as a blanket treatment, when someone comes to us in febrile encephalopathy in this season, we should not be forgetting to treat them with oseltamivir also till we have further answers. Encephalitis, they may have a continuous seizure. And we have the rarer immunological complications like ANEC, acute necrotizing encephalitis also. We've had a couple of cases of that also where if we do an LP, the cells are clear. There is no direct bacterial invasion, but it's the immune system which acts and the CNS takes the hit. We have had acute uh, necrotizing encephalitis also. Also, we have had other multi-system involvement like renal insufficiencies and liver where the transaminases are high and they settle down slowly. So we should not forget that it's a multi-system kind of an involvement.
Yeah, we had a case recently detected, referred by one of our colleague, and it was a case of minimal chain nephrotic syndrome, but developed respiratory symptom by evening. It was in shock, where we had to ventilate and treat, and of course it was positive, and nasal swab was positive. We treated and came out nicely. Of course, the question is that why we should be worried, why we should do swab, and why we should do give oseltamivir very early and judiciously is to prevent the complication and to avoid the further progress.
Right.
Dr. Anil, you are one more one more additional qualification. You have, you're an allergist also, and you see a lot of asthma patient. Giving this flu vaccine, how much is beneficial? What is your message related to that?
No, definitely, especially someone who is wheezing. We have children, older wheezers, and the requirement of relapses or frequent attacks will definitely come down with the influenza vaccine. Their disease control, asthma control, when we talk about the asthma control, uh, influenza group of viruses are the ones which will have this acute exacerbations very commonly. And by using this flu vaccines, and these exacerbations can be controlled. People vouch for it. The people who have taken a flu vaccine or they have
They
experienced influenza before, they'll not forget it. They will come and remind us, doctor, this monsoon season is coming. I'm come here for
Yes,
the flu vaccine.
yes.
The older asthmatic children will remind themselves.
Absolutely, patients tells that they know the awareness is important, and they know that they have been benefited. So next season they'll be alert and they'll come. How early we can go? What is the ideal season?
In Bangalore or in Karnataka, when we are practicing, the ideal season is to do it just before monsoon season. So probably June, early July or June probably will be a good timing to consider the flu vaccine and visit the flu vaccines.
Okay. That's by Dr. Anil, and he has covered from mild symptom, moderate symptom, nasal swab, comorbid condition, and high dependence area, how to take care of the patients and what are the complications, everything. Anil, just give me the take-home message.
From my side, I think we should have our antennas up in this flu season. Uh, we should know that Oseltamivir is quite a safe drug. I think we should not have any reservations in using Oseltamivir in the deserving people. At the same time, I want to discourage usage in the where there are no indications. Better not to use it in mild category A. But also we should have a idea as to who are the high risk group. So by treating the patient, it's not just the patient, it is for the other high risk people in the family who will be protected by it. So we should know what are the high risk groups. It's a safe drug which can be used, and at the same time avoid indiscriminate use so that there is no resistance which is being developed for this drug.
That's nice. Actually, for the delegates, we never shared questions to Dr. Anil. It was just I myself prepared, and you gave very good optimal scientific information. Thank you, Anil. And
Thank you,
Anil
sir.
has covered everything related to mild to moderate illness, use of vaccines, when to resume back to school, comorbid condition, and HDU related issues, everything. Thank you, Anil, from the organizer as well as from my side.
Thank you,
Thank
sir.
you, Dr. Somshekhar.
Thank
Thank you, Dr. Anil. This
thank you.
Any
question
question?
answer session was very practical and gave a lot of insights to doctors who have attended. I'm very sure more than the theory, these insights would help people in practice. I mean, this is what doctors actually look forward to.
Yeah.
Thank
Any
you so very
questions
much.
to take up? If it is there, I'll.
Yes,
Nothing
sir.
has
There are,
come.
sir, please
Yeah.
excuse me.
Yeah.
There are some two questions from the audience.
Yeah. I'll just.
You
I
can
will
please
just.
ask. Yeah, you can please ask.
Shortly there.
Yeah.
Where is that? One minute. I'll just take it.
Yeah.
Sir,
Yes, Amrut,
what
you
is
can.
either
You can.
side effect in respiratory during Oseltamivir consumption? Is there any side effect in respiratory health during Oseltamivir consumption?
No, in respiratory wise, we don't expect any side effects in the respiratory system because of oseltamivir consumption. Usually this drug can, because it's a pro drug, it gets converted, it can have mild GI symptoms. Usually the most commonest reported is the nausea, vomiting, and which is self-limiting. So sometimes we end up using some proton pump inhibitors. When they come back to us with these symptoms, we end up using proton pump inhibitors, and usually we advise them to take this medication after food, which will reduce its gastric irritation and the nausea kind of symptoms. And usually this resolves after a couple of doses. Usually these symptoms resolve. Respiratory wise, we have not come across any complications.
Okay, sir. And one more question from the audience, that is, in lung infection, can we use Oseltamivir?
Yes,
It might
of
be
course.
repetitive, yeah.
Yeah, of course. Whenever there is a influenza-like illness which is suspected, a pneumonia in this epidemic season, awaiting the swab, we don't wait. If someone is sick enough to get admitted, warranting inpatient treatment, requiring oxygen, in respiratory distress, I think we need to go ahead and start them on oseltamivir and the antibiotics, depending on the situation and the clinical judgment on case-to-case basis. That call needs to be taken. Yes.
Okay, sir. These were the two questions. Yeah. Dr. Prashant,
Thanks.
sir.
Yeah, thanks once again, sir. Thanks, Dr. Somshekhar. Thanks, Dr. Anil. Thanks all the audience who took time from their scheduled and OPDs and attended this session. Thanks marketing sales team of Hitro, and thank you IT team for their support. Thanks
Thank
all
you.
of you. It was lovely. We can sign off, sir. I
Thank
wish
you.
you a very pleasant evening.
Thank you, sir. I would like to extend my heartfelt thanks to
Thank you.
Dr. Somshekhar for conducting
Thank you,
this
Dr.
wonderful
Anil.
session. I think
Thank you,
the
sir.
way he asked the questions, I think it covered most of the issues or the questions I think as practicing pediatricians would have.
Yes.
Thank you, sir. Thank you so much.
Thank you. Thank you so much.
Thank you, Dr.
Thank you.
Prashant.
Thank you. Bye.
Thank you.
We can
Dr.
sign
Anil
off. No problem.
and all the team and all the delegates. Thank you all.
Yes. Thank you.
Dr. Anil and Dr. Somshekhar. Sir, I really want to apologize because on the last minute,